I've created is a space for us to really engage in a discussion. And so there's going to be times, and it's, there's a, y'all know each other. I know I'm the newbie, but I've been here before, in these spaces with y'all. But the key today is I really want you all to think about, how does this apply to my work? And what can I do to implement today and moving forward, and what are some of these conversations that we should have in this area? And there's going to be times where I am, for those who feel comfortable, to get off the camera as well, to turn on their camera as well too, so we can engage in this discussion together. So we will have that opportunity, because I would like to see y'all. I'm fortunate to see some folks, but it would be really good to really create this space of learning and growing together, because I'm going to learn with you all as well. So that's the space that we're creating. So with that being said, I'm going to pull up my slides. Um, and can you all see my slides? Is it good?
We got you.
Okay, sounds good. So one of the things, so if you notice on this slide, if not now, when? I really think that as we're thinking about these things around prevention, race, and social determinants of health, the time is now to act. And we all have a role to play in this process. So I think that that's what's key in the process, is that we're understanding that we all have a place. And so the purpose of today, just to guide our discussion, we're going to define and apply key concepts, because I always like to make sure that we're speaking the same language, because we use these terms interchangeably. But health disparities and equities, social determinants of health, and all of these. But one of the key things is we're going to take actionable steps towards promoting health. And then as if we're going to talk about race, the goal is racial equity. And really, how does that flow in our spheres of influence? And then we're going to talk about the strategies, because like I said, I can't invite you to do the work if I don't share the work. So there's going to be opportunities where we're going to talk about the strategies. And then just to recognize your role, because like I said before, we all have a role in prevention, as prevention professionals, in driving equitable change. But before we engage in the discussion, I just think it's very important to think about how we're going to engage. I do not, I always like to start my meetings with community agreements, whether if it's a community event, meetings, I always start with community agreements. And I'm going to go through these, and then I'm going to invite us all to, agree to them. Speak from your experience, use I statements rather than generalizations. Be curious, open, and respectful. Call people into the conversation, and mutual understanding rather than calling anyone out, because we're learning and growing together. And all of us on this journey to promote equity and justice and all of these different roles, we're all on a journey, and we all make mistakes. Seek to understand perspectives that differ from your own. Listen deeply and ask questions. But then when we're engaging in these discussions, the little check mark says, honor and make space for quiet internal reflection. Because sometimes we feel like we have to fill up the time. But we need to give people, as we're talking about some of these things like race and all these complicated matters that we've been contending with for centuries, it's important that we also have that quiet space to give people a moment to kind of reflect. And then, like we said, learn from each other, take space, and make space, and be mindful of diverse perspectives. And then asking clarifying questions instead of making assumptions, because that's what we do when we're learning. And then here's my favorite, the whole oops, ouch, and whoa. Sometimes when we're having these discussions, someone might say something that's a oops. That's where these microaggressions will come out, or just someone might say something that's more of an oops, on my end. The flag is on the field. And then an ouch, when we think about ouch, well, if you hear someone say something, because sometimes when we talk about microaggressions, sometimes they're stated and people aren't even aware that they've said something. So in any of my meetings, if someone says ouch, that lets me know that, okay, something's been said and we need to address it. And then as we're also engaging, whoa is, okay, Cerise, you're moving too fast. We need to slow down. And so so throughout this conversation today, if someone says oops, ouch, or someone needs a whoa, I want to invite everyone to engage in this. And this is a way to get rid of some of those unintended harms, those those implicit bias or unconscious biases, those statements that come out in our conversations. And then what I always like to end with is extending grace. And so as we engage today, I always like to ask everybody, so I'm going to come off and ask, can we agree to these agreements today as we engage in the discussion? Can I get some emojis, some head shakes? This is the interactive time, y'all. Are we agreed? Is there anything missing from the, okay, I've seen some thumbs up. Y'all engage and I appreciate it. Is there anything missing? Wonderful, wonderful. Oh.
I think we're set.
Okay. So when we think about these things, I always like to lay the foundation and really start with how do we get here in the process. And we talk about health disparities, and this is something that is, been going on for years, and the definition has evolved. But it's, when we think about the disparities, it is just a difference. But what we're noticing about these differences in health disparities, it's what the second sentence really states. It adversely affects groups of people who have systematically experienced greater obstacles to health based on their racial or ethnic group, their religion, socioeconomic status, gender identity, age, mental health, cognitive, physical abilities. All of these different things, geographic locations. And then how it ends is key. Historically linked to discrimination or exclusion. So as we're thinking about these differences that we're seeing, we can also think as system, we're hearing this term system, and historically linked to discrimination or exclusion. But then we think about, health equity. And it's the attainment of the highest level of health. And look what it says, for all people. It doesn't say some groups. It doesn't say other groups. It says all people. And so when we think about equity, we should always, and we're conducting our work through an equity lens, we should automatically thinking of who's benefiting and who's not benefiting. That's simply what equity is saying. Because when we think about our services, we typically know who's benefiting from our services. And then we have these certain groups that aren't benefiting. And what equity is going to challenge you to do is ask the questions of, well, why isn't this group? And is there some trends about these groups that of these all people? But to remember, when we're talking about equity, we're really talking ensuring that everyone is thriving. So achieving health equity requires valuing everyone equally with focused and ongoing societal efforts. And then societal, we make up the society, efforts to address avoidable inequalities, historical and contemporary. So we can't erase history. We got to acknowledge what has occurred historically, because the history is impacting today. And the contemporary injustice, we can't ignore what's going on right now in the apparent moment, and the elimination of health and healthcare disparities. So this is, if we're not thinking of equity, we're not going to address the disparities that we've been seeing for centuries now. And I really like this graphic, because it really makes, when we think about one's health, and we think about, we typically go to just one's behavior, in the matter, and what we're learning, that it goes beyond just one's health behaviors. That as this picture shows, that health behaviors makes up 30%. So if we're looking at someone who's using substance or smokes and their behaviors, that just makes up 30% of their health. How we eat, how we care for ourselves. Then we look at genes and biology. Well, that only makes up 10%, so 40%. But if we look at these other systemic factors, once again, that word system keeps on coming up. Clinical care, physical environment, and social and economic factors really impact one's health. And so if we are truly about promoting health and wellness, we have to make sure that our interventions are addressing not only the behavior, because we focus years on behaviors, looking at behaviors because we want that individual. You need to change your behaviors. You need to do this, and you need to, and we're going to talk about that when we really think about, trying to get someone to just change their behaviors. But the reality is we have to look at all of these other pies, and really social and economic factors need to be considered as we are making our decisions. And so health inequities, because I'm really, as I'm continuing to evolve, I've really kind of moved away from really just saying the disparities to really saying we're really looking at inequities. And those are differences in health statuses or in the distribution of health resources between different population groups arising from the social conditions in which people are born, grow, live, work, and age. And they result from systemics. That system keeps on coming up in this conversation. Avoidable and unjust social and economic policies and practices that creates barriers to opportunity. So when we're so if we know that, so as I do a lot of work with organizations and really trying to help organizations shift. I'm starting at the Colorado School of Public Health as the associate dean, but I've worked with state government, local government, and various entities. And the first thing that we do is really look at your policies and practices and examine, and is there any policies and practices within your structures that are creating barriers for opportunity? And that's really because it's these opportunities that people are missing that is creating the health differences that we're seeing within various groups and populations. So really addressing the systemic issues. And so this goes into the social determinants of health. And really looking at the social determinants of health. And I really like this picture, and this is from the Bay Area Regional Health Inequities Initiative. And this whole really looks at, and as this slide, it looks at the conditions for early childhood development, education, employment, income, and job security, food security, health services, access to services, housing. It really looks at those conditions. And we hear those upstream and downstream approaches. So if you look on to this right-hand side, the downstream is just looking at the individual disease and those different areas, but really an upstream approach is really looking at how people, the living conditions, the inequities within our systems. Really, if we're really going to see change in health, we have to have more of an upstream approach. We have to expand our partnerships, because we have even in public health, we do a lot of work with just public health entities. Well, we know if we're going to address any of the economic and barriers, then we have to have the labor folks, and when I worked at the state health department, I used to be the health disparity specialist for the state of Colorado. And in that role, the governor had convened a health equity committee, which all the state agents, education came together, labor department, child welfare, public health, healthcare policy and finance, all of our Medicaid people. We were all working together to create our equity agendas, because if we're going to see anything as state level approach, we knew that it couldn't just be public health at the table, that all the different policies and practice, and it goes back to what this says, that all of these, that our partners in the labor, job market, they could be creating some of their policies could create barriers for opportunities. So this was a way that the governor and working at a state level to really begin working together and as state agencies to promote equity. So everyone had to have a health equity agenda. Whether you were the education department, there was a whole push to make sure that we all work together and really addressed an upstream approach and really looking at the communities, utilizing data. Data is our friend because the data is going to tell us who's thriving and who's not, what groups, working together, who do we need to partner. And in these efforts, when we're thinking about the social determinants of health, it's very important that you are partnering with the community as well. So that's equally as important as we're engaging in this work. And so here's just another depiction when we're thinking about our healthcare, factors that contribute to health inequities, individual, we look at the behaviors as providers. And this is providers across the board, really not being equipped to be culturally responsive. We need to know not only the cultural, but the linguistic needs of all the individuals that we serve. And then we also have to check our own bias. Because bias is as natural as breathing. And so if we know that bias is as natural as breathing, it's important that as providers, as prevention professionals, that we are really thinking about, okay, I know my bias because I've done my work. And we continually do our work. We can't just check it. And I went to a bias training 2 years ago, or Carlton set up this awesome training that we had. It's not a one and done. It's a continual aspect of really knowing your bias, because you could be causing harm, that unintended harm to individuals. Then we can look at our systems, and it says health, but we can look at all of our systems, how it's organized, financed, and how services are delivered. And then when we think about the social and environmental factors, it's looking at poverty, education, proximity to care, neighborhood safety, and then racism is also a social determinant of health. And so it's not that certain groups that the diseases are just chasing after them. That's not what we're saying. If there are systemic issues that are contributing to the inequities that we're seeing. So then we're going to have to start talking about racism and really how does that influence the work that we're doing. And so, as I stated, we'll use COVID-19. I was like, and really looking at what we learned from the pandemic, and given the existing impediments to care for Blacks and Latinos due to the social determinants of health, the COVID-19 pandemic placed those with behavioral health problems at even higher vulnerability. What we found out with COVID, Blacks and Latinos have lower access to needed treatment. So those are the systemic issues, often terminate treatment prematurely and experience less cultural responsive care. Black and Latino communities are continuing to deal with the opioid endemic while now in the midst of the COVID-19. This is some of the trends that we learned through COVID-19. And so Blacks and Latinos have limited access to prevention treatment and recovery services for substance use disorders. So if we know that and know that, then we have to think about, well, why is that occurring and what do we need to do in these different areas to ensure that groups have access to care and have access to treatment, that our messages are reaching the community. And so I always like to define racism, and I love Dr. Kamara Jones, and I like this definition, and she also has a great resource that we can, I have a resource list at the slide that really helps explain racism as a framework, and really I've utilized it on many occasions. But as I read this, racism is a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we all call race. And then, but what we know about that, that it unfairly disadvantages some individuals and community and unfairly advantages other individuals and communities and saps the strength of the whole society through a waste of human resources. So it's a structure and it disadvantages. And that's when we're thinking about race, and it's all based on one's phenotype or group that they're assigned to. And so I just want us to take a moment to pause and think about what effects does racism have on the health and wellness of the communities that we serve? Do we see that there's anything? Is there any impact? So this is the opportunity to engage. And do you see any aspects of with the work that you're doing in prevention?
And folks, I want to remind everybody that this is a safe space that has been created. We've asked folks that if you want to share anything, please do so by indicating so by raising your hand. You can put some things in the chat. We're following the chat as well. If you feel comfortable, please, we'd love to see your lovely and handsome faces on today. And so we appreciate you all. But let's get into this conversation. So what effects does racism have on health and wellness of communities that we serve? Please.
Yes.
Dr. Harrison, go ahead.
Most of the folks on this call right now know about the community that I work in. But I just wanted to let you know that I work in a community is 3.39 square miles with 13,000 people in it. And low socioeconomic, African-American, and Latinos. Okay, so one of the slides you just put up about the COVID thing, I really have questions about that one because we tried, many attempts were made to get the vaccine and they just wouldn't take it. So it was accessible. But on the other hand, overall, what you're saying is so correct. We have, on one hand, we have the African Americans who have access to health care, but, because of work schedules, lack of transportation, all of those issues prevent or inhibit the children from receiving the health care. Then on the other hand, I have the Latinos who don't have Social Security numbers. They don't have access to Medicaid. And so then again, they it's different reasons. But yes, I understand exactly what you're saying. And that's why I really wanted to participate in this training.
Awesome.
Thank you. And Shaniqua also offered that while her mic isn't working, she's been in both the private and the public sector and found that individuals with private insurance get better services versus those in the public sector who are with Medicaid and Medicare.
Yeah, I agree. Dr. Webster has a hand up.
Good morning. Thank you, Dr. Harrison. I just wanted to say I am from a rural community in Louisiana. I live in the capital city of my state now. But what I have noticed is that in rural communities, mental health access is very, very limited. And I think with COVID, it kind of helped those communities in some ways because now individuals have the ability to access mental health treatment through telehealth in some ways. Currently, the Louisiana legislature is considering what they call the social work compact agreement, where providers can offer services through telehealth, not only in Louisiana, but in other states. And I think that's going to be a game changer for our rural communities throughout the country, where access to mental health treatment is available to help overcome some of the disparities that we now see.
I also would like to just add, Dr. Webster is over the counselors at East Baton Rouge Parish School System. Children without Medicaid cannot receive services even in the schools. But we were able to go through Dr. Webster to get a private agency to get the necessary requirements and provide those services to the children in the school system.
That's awesome. So that whole notion of partnership, recognizing and addressing and knowing your communities. I really appreciate that, Dr. Webster. Even I live in rural, I serve a rural. This has been a challenge. It's knowing your communities and stopping and pivoting, because that's what I heard. We need to bring in a partner to talk and address this concern, because we know that there's a group that's not accessing services. And so I think that that's wonderful, and that's what it takes to promote equity and justice, where we're constantly, equity is saying, I'm looking to see who's benefiting and who's not, and then we're gonna be, and prevention in and of itself, we're gonna be proactive and ahead of the game and provide services and partner with non-traditional partners, showing them the need for this to ensure that our communities thrive, and it's everyone's thriving. Carlton.
Dr. Hunt, I just also hear in the conversation, this is such a rich conversation, that very often in prevention, we utilize the term race, but we think of it as a monolith. We think of it as only one thing and not considering the distinctions even within our culture, even within our context, right? And so those that are in purely urban kind of contexts and circumstances, who happen to be Black or African American or Latino, are experiencing these systems and these systematic issues differently when they are in rural areas and contexts. And those are things that we don't often talk about. And so I love that that was brought up.
Awesome. Well, thank y'all. That's exactly what we want to create the space. Dr. Webster?
Yes, I also wanted to say that unfortunately, there is a misunderstanding too about mental health and wellness. I think there's still a stigma associated with mental health, and so much of what we're having to do is to provide education around what is mental health, how can we increase our ability to function well, which affects our physical health as well. And so we work to do a better job at educating about mental health awareness and reducing the stigma of having to deal with a mental health issue. Because truthfully, anyone at any time can experience something that affects their mental wellness. And I think that as we continue to educate, particularly in the minority communities and in rural communities, hopefully the understanding of addressing things early, again, prevention, will help to make a difference.
Well, thanks, everyone.
I just want to comment what Dr. Webster said. Like, I totally agree with her. And on that context, we cannot forget culture. Like, because when we talk about mental health and stigma, we need to have in consideration culture. Like in my culture, like what is mental health? Like where I'm coming from, how we see talking about depression and talking about sadness, how we look at those things. And I'm very comfortable like to address that. Like in America, in most of parts of America, it's okay to go to a therapy. In fact, in New York, it's very fancy. Everybody is a therapist in New York, you know? So if you don't have one, oh my God, what's wrong with you? But but in some other parts, that is not okay. So how we put culture in the center of the conversation and trying to figure out how we solve that.
And it's we. I like the collective we, because if it's a systemic issue, it's not the groups coming together on their own. The folks in the positions of leadership that can make systemic change, we are partnering together with community to really create culturally responsive care. That's why when we created the Colorado Black Health Collaborative, because people will say, are there Black folks in Colorado? And I was like, yeah, we here, and there's enough. We're not the largest group by far here, but we're here, and we have to come together with in the place, the mental health providers, therapists, clinicians, and partner together to create this whole messaging. So I'm doing some work right now with the community on a messaging campaign to really talk about, okay, what's the best ways? And what are we doing? What sits right? Does this land well with you in the community? If I were to bring this information, because I become part of the CU system. I might be a Black woman in Colorado, but when I come and step on this campus, or when I walk in community, they're like, Cerise, you work at CU, and you represent CU. But the point is, to be culturally responsive, I'm going to listen to the needs as stated and adapt and modify our programming, our evidence-based models to be culturally responsive. And that's what's key. So often we'll take a blueprint of something, and I'm not knocking it, but if you do not bring community in to help influence, that message is going to continue to be disregarded in the process. Well, thank you. This is exactly, we'll have another moment. I'm going to jump back to the slides if there's not any more questions or comments. I know, Carlton, you got the chat going. Okay, cool. Okay, so now we're going to get into, we're talking about like structural racism. And really it's a combination of systems, public policies, and I put this in blue, institutional practices, the way we do our work within our institutions that denies rights and opportunities for people of color. It includes institutional norms that work in various and often reinforcing ways to perpetuate racial and ethnic inequities. And then I got this definition from the Aspen Institute, and it reflects dimensions of our history and culture that preserve systemic social and economic disadvantages. See, that's that word. When we talk about racism, it structures it advantages some and disadvantages others, marginalization, and denials of rights for Black, Indigenous people of color, and have allowed these wrongs to adapt over time, to endure and adapt. And so it goes on and on and on over time. And so so when I started this conversation that we're having, the key aspect was we have to stop and pause and look at our policy. Like the example that Dr. Webster provided, if you know right now our group is not benefiting from your service, we need to stop and pause because our policy isn't working. We can have access to, we can provide therapy and therapeutic services, but if we don't have providers in rural areas, then there's a lag. We got to stop, and it's going to disadvantage a group. So we have to stop our practice to say, okay, we need to do more telehealth. But we also have to challenge ourselves to also think about, well, how can we get the services in the community as well too? And it's that constant looking at that our institutional practices. And we also got to make up, when we talk about the system, who makes up the system, y'all? Who makes up the system?
We do.
We do, exactly. So we make up the system. So it's very important. And so our whole charge in a lot of the work that what we're seeing is really racial equity. And it's racial justice, or racial equity is a systematic for treatment of people of all races, resulting in equitable opportunities and outcomes for all. And it goes beyond anti-racism. It's not just the absence of discrimination and inequities, but also the presence of deliberate systems that support to achieve and sustain racial equity through proactive and preventative measures. And so I like this depiction, and I know that the Robert Wood Johnson Foundation has updated, but it really talks about how our good intentions can impact how we're doing our work and how we're doing different things.
Dr. Cerise, I'm sorry. I think Dr. Webster has a question
Okay.
on the slide.
Yes. In the previous slide, thank you, Ms. Paula. You talked about access, and one of the challenges that we've noticed in Louisiana and what we now know is around the country, there is a shortage of mental health providers. One of the reasons for that is the test to acquire the license is biased against people of color. And so there is a large percentage of potential providers who are not able to move forward because they cannot pass that licensure test, which creates a shortage of providers. That's a huge problem that, again, it has to be addressed across the board, not just for mental health, but in all aspects of health and wellness.
Absolutely. And so that's a great example of a systemic issue that is creating an inequity. And we know how testing bias, there's plenty of research around testing bias. And so when we're thinking about licensure, that's when we're shifting into that national conversation. See, this is when like the Social Work Association, the National Association of Social Workers, all these different licensing and that's how we need to organize on a national level. So that's not probably even just a Louisiana concern. This is when we think about there's an underrepresentation of therapists of color throughout our whole nation. And it's probably due to some of these systemic barriers. And that's the kind of movement we need to address on a national level through our licensing organizations and challenging them to change. And we see change, just like the GRE was removed. So a lot of graduate schools no longer require a GRE testing. So it works when we organize at a national level to see those changes. So it's not a requirement for most graduate programs. Dr. Harrison?
I also was thinking about the slide when because of the situation that happened here. Well, I liked when you said, who's the system? And you say, we are the system. Okay, and so sometimes we need to speak up. We had a situation when I started working in this community, and I often ask myself, is this racism, or when they say the squeaky wheel gets the oil? Okay, so we chose this site because we wanted the 14-acre park that's connected to it, but the park had nothing in it, and they didn't even have a playground, and it was a park. But the city, the park system, had meetings across the city asking for input. Okay, but the people from my little community had not given their input. So when we came in, we started, working with them and so on. But anyway, in the end, we got $350,000 and renovated our park. So then the question is, was that racism, or was that we, the people, didn't engage in what? So, I often think about that.
Yeah. Or if it's a systemic issue. So I think that as we look at the structural and the aspect of it, that there was an inequity in a community that might have not had, but as you all organized, the system changed because it was brought to people's attention.
Yeah.
And it kind of goes back, what I think, Dr. Harrison, is if we're not paying attention of who's being served and not being served, we can unintentionally be excluding groups. But what happens is typically that same group that always gets forgotten in that process.
Yes.
So that's what it's, y'all, this work is complicated. But what's good is if we're stopping, pausing, and reflecting, That's what we have to do, is really stop, pause, reflect, and then strategize, and really look at the systemic issue and see that it's addressed. And I really appreciate, we all have a role to play in that, and really stopping and pausing in our work. Paula, did you have something? You were off mute for a minute for quite a time, so I want to give you space.
Oh, no, I'm okay. I'm just like work the room to see who has something to say.
Okay,
I'm
right
good.
on.
I'm good.
And I appreciate you stopping me, because I can't see as well
Yeah.
with the slides. So
Yes.
I
No,
appreciate
you
that.
good.
Yeah,
You
'cause-
good.
okay.
I'm just inspecting the room.
Okay, right. Okay. So I'm gonna go back to this picture really quick, and if you all can just flow with me, let's pretend like we all got some bikes, and the state has given us some bikes, a foundation, and one of the things that we know is
The Cerise, okay, I think she was,
Yeah, she
okay,
did.
she's back. She's back.
okay. Sorry, I didn't.
Okay.
Yeah,
No,
I was
you're good.
talking and didn't even know I was gone.
No,
So
you're good. You're good. You was
okay,
just
It
for
was
1
just for
second.
half a second.
Yes,
okay,
yes.
and I didn't even know I was talking. Yeah, I was talking to myself. so let me go back.
You're
Sorry
good.
about that. I'm actually, yeah, so sorry.
No,
You're
you're
good.
good. You're good.
Um, so, so I'm just gonna go back. If we receive funds from, to give our bike, our whole purpose in our project is ensure that everyone in our community has mobility via bike. And to be fair to everyone and to think equality, we're gonna give everyone the same bike. And we save money that way, because then I can just run to Costco, get a bunch of bikes at Costco, and it's the same price for everybody. But if we look at equality for this first person who, has different mobility needs, the first bike didn't work for the first individual. Then we go to the second person. This bike didn't address. Although this one bike did address one. And so 1 out of 4. The message that it sends to the community is, I don't know your needs. You didn't care about our needs. And so we might have been some good intent, had some good intent, but we didn't address the community's needs. So then when we think about equity makes sure that people have the type accommodations that they need. But the thing about equity, and what makes equity work gets real when we start doving out dollars, because I can imagine that this first bike for our person who has a different mobility need is different from the second bike. And so it's not means that it's all going to cost the same. But if we allocate the resources, we will get to our vision to ensure that everyone in our community has the mobility that we need. So it might not mean that each bike is going to cost the same. You might have to allocate more resources. And that's when we're having real equity conversations, when it's about allocating resources into the conversation. Yes.
Dr. Cerise, I love that photo. You know what? See, they were looking at it as somebody who was in the wheelchair, but look, I'm going to buy that bike for myself because I'm getting older. And so when we do bike rides in Gardere, I'm going to be on my bike right there with those children.
But
Yes,
the Cerise,
And let me tell you, and what gave me we have a bike shop in our park now. And so we go to these bike rides, So AARP had an announcement out at the beginning of this year, and I was going to buy 20 of those bikes. But then I found out at the last minute that in your mission statement, you had to say that it was you served people who were 65 and older or something like that. So then I couldn't apply, but I'm going to buy my own bike and it's going to look just like that. And so when we're going down the street with our bike ride, I'm going to be right there with those children.
With the children, creating community
Right.
and belonging.
Mhm.
See the thriving with community, addressing a need. I'm sorry, Paula.
And I need to share this with you because every time I see that slide, and that's what I thought that Harrison was gonna come with that example, and that's why I was laughing. Some Christmas ago, I was part of this group that was doing Christmas dinners. So, and because I volunteer in Gardea, I told the Harrison, like, can you give me like a family that we're gonna bring one of these Christmas dinners? We're gonna have half a turkey, and it was like some items I don't remember. So the Harrison said, what I'm gonna do with that? Most of my families have 6 children, and so me, I said, they're gonna share the meal. So they're gonna share the meal. She said, that's not gonna do anything for my families, Paula. And in my head, my intent was good. We were giving half a turkey to everybody. Everybody was gonna get the same thing. And like the way, look at her face, that's what she did. She looked at me and she said, really? I don't know what you're learning. Like, do I need to still giving you the lesson on equality? I'm like, no, ma'am, I got it.
And she has that same picture on the wall in the LCPR office.
See? So it slips in. So it does. And that's that intent. You really have a good intent, but it can slip in the message that it sends. And like I said, it's typically the same community that gets the same message from the same system. So they looking at you like, here we go. Carlton?
Yes, Cerise, thank you so much. And I love this conversation, particularly about that slide. Shanika offered a really, I think, important and great insight in terms of the fact that equal or the equality represented access to everyone, but it didn't necessarily represent looking at the individualized needs of everyone, which is what equity is representing. What I also share with folks is that that picture for me represents opportunities for us as preventionists. Each one of those individuals represents different segments of our community. And what that slide actually represents to me is our opportunity to demonstrate that we care enough to ask the important questions that are necessary, right? And so we ask questions at the point of engagement, at that point of access. And I refer to them as equitable questioning that we can put together. And that equitable questioning represents, are we, is the program that we're offering in the SIS or the project that we're providing, the resource that we're offering, does that represent continual status quo? What does that still reinforce the status quo? Or is this an opportunity for us to address some of the implicit bias that may be within our society? If we don't ask those questions, we will end up giving the wrong types of bikes consistent and thinking that we're doing something. So that picture that you show represents a number of things in my view.
Awesome. Thank you. Thank you, Shanika, for your comments as well, too. So this is wonderful. I have another picture, so I'm going to show you another one. So I hope you all enjoy this one as well, too. So this is another one that looks at inequality. And this one's really looking at, so we have this tree, apple tree. And as you can see, it's tilted over to the side, to the left a little bit. And inequality is there's unequal access. So you see an apple's coming down for the one person on the left, but on this right side, even the apple tree is not even thriving and is flourishing as well. And the person on the right's not having any type of, is not getting any type of apple, no fruit. So equality is going to say, well, let's just give them ladders. We're going to evenly give everyone a ladder so that they can access the apples. Well, evenly distributed, this is how the system talks about. We'll just do it evenly, we'll give tools and assistance. Everyone gets the same one assistance. We're not going to look at the unique needs. But as you see, when we have that equality mindset, we have this individual to the left. Once again, they're still getting apples. The matter of fact, has a little bag and it's filling up. And then look at this person to the right. Still, even with the evenly distributed tools and assistance, still not getting an apple. Now, and we know in these processes that there's years in between services. It's usually not something that's addressed really quickly. So if we go into equity, with equity, we're going to give custom tools that identify and address inequality. So now the ladder is taller. We have the person getting apples. Now, but I do notice that still just one side of the tree is still thriving better than the other. But you know what? This person to the right needs to be grateful that they're even getting apples at this point. So let's not even worry about that. You know, and we addressed it. We addressed equity. We did our part. And then if we really want to continue to move in this process, we kind of think about justice is really fixing the system to offer equal access to both tools and opportunities. So now we've known for years that that tree is not thriving. And so now we're going to bring in some structures and put some structures in place on both sides of the tree to ensure that it's equally fulling and thriving. This is addressing the systemic barriers and really examining our structures and providing services, you know, fixing the system essentially. Offer equal access to both tools and opportunities. And this goes back to what Carlton has stated about opportunities. And so one of the things that I think is very important, and we're seeing a shift on the political determinants of health, and it's really amplifying the work that we're doing around the social determinants of health, and really looks at the systemic process of structuring relationships, distributing resources, and administering power. It's operating simultaneously in ways that mutually reinforce or influence one another to shape opportunities that either advance health equity or exacerbate health inequities. So it's really, the political is really examining the systems and how we engage. And one of the best ways to really talk about the political determinants of health, and this is what I want you, how many of you have really been engaged with Daniel Dobbs's work in all this different area? I think it's very relevant, and I appreciate them taking it to another level of looking at the systemic and what needs to be done. Because this kind of goes back into what Dr. Webster is doing, stated about the licensure structure, you know, and the way we're creating licensure and how that's, you know, perpetuating some inequities, the political determinants of health. And so I'm going to show a quick video. If y'all want to bear with me real quick, I'm going to pull together a video that helps explain the political determinants of health. Let me make sure I have everything set and ready to go.
To best grasp the political determinants of health, let's examine a hypothetical example that combines experiences of real people in urban and rural communities. Imagine a 19-year-old woman, we'll call her Jessica. After enduring several miscarriages, she barely survives giving birth to an infant 9 weeks early, the baby weighing only 3 pounds. Her son is placed in the neonatal intensive care unit, the blood from his umbilical cord revealing over 200 toxins. Where did the system fail Jessica and her baby? How and why did these results occur? 3 years earlier, Jessica had left her parents' house. Access to treatment for her dad's substance use disorder had been eliminated when policymakers closed 3 of the city's public community health centers to save money. Contending with his wife's lack of education, neither of Jessica's parents could secure a job with a livable wage, prompting serious and substantial mental health conditions. Jessica moved to a low-income neighborhood in the city. she never knew of the extent of how the appalling conditions of her neighborhood were politically determined. For example, determined to keep housing segregation in place, politicians expended very few resources to build sidewalks, parks, or recreational facilities. Healthcare providers refused to operate in Jessica's community due to poor reimbursement rates from Medicaid. Because they resisted creating bus routes, lawmakers dissuaded grocery stores from operating in the community, preventing residents' access to fresh fruit, vegetables, and meat. Simultaneously, policymakers altered zoning laws to permit development of a dump site and a chemical plant, switching the community's water source from a clean river 10 miles away to a nearby polluted river to save money. This water was used to drink, bathe, and wash clothes. It also irrigated the lawn at Jessica's apartment building, adding to the list of pollutants and environmental hazards in her neighborhood. And because her district lacked established tenant rights, her landlord had no interest in improving unhealthy housing practices. Jessica found work as a cashier at the corner convenience store, a job with no employee benefits, including health or disability insurance. Because policymakers rejected proposals to increase minimum wage to a livable income, Jessica often substituted her employer's free snacks policy as a meal, never realizing the effect that high-fat, high-sodium food would eventually have on her or her baby's health. With local politicians striking down an effort to ban smoking in convenience stores, Jessica was constantly subjected to a barrage of secondhand smoke. And when she discovered she was pregnant, no attempt at receiving health insurance coverage was successful. Her non-ACA compliant plan denied her maternity coverage because they viewed her pregnancy as a pre-existing condition. Medicaid, the government's health insurance program for low-income families, denied her coverage for not being poor enough. After finding a ride to the free clinic, Jessica waited more than half a day to be seen by a second-rate physician, a doctor who was condescending and offensive. Realizing she could not afford to take more days off from work, she never went back. At 31 weeks, a neighbor drove Jessica to a hospital ER 20 miles away. Seeing that Jessica was experiencing excessive swelling in her face and ankles, as well as seizures, the emergency team decided to deliver her premature son immediately. Due to complications, her newborn son was sent to the neonatal intensive care unit. Once his organs were deemed mature enough, he was taken off the machines and sent home with severe cognitive defects. And in their apartment, Jessica and the baby were exposed to mildew and cockroaches, causing her son to develop respiratory problems. The landlord refused to remedy the poor conditions, telling her to move if she didn't like it there. Jessica struggled to find early childhood care and access to schools with educational assistance, healthy food options, and other resources needed to thrive. Because their school and community lacked the resources to enable Jessica's son to even barely reach his potential, he dropped out of school after entering 8th grade, just as his grandmother had done, repeating what is surely the ongoing rule of poverty. Jessica's story shows the compounding effect of political determinants over personal responsibility. No matter how reliably Jessica tried to act, structural, institutional, intrapersonal, and interpersonal obstacles stood in her way. Political determinants were pulling strings that prevented Jessica and her family from achieving optimal health and their full potential. What does this mean for all of us? What can we do to improve and mend our community's most damaged systems?
Okay. So I utilize that video because I think that it's a great way to explain the political determinants of health, and it really is a summation of all the work. But I do want us to kind of stop and pause and just really consider like how the system really created barriers for Jessica. Because if we're not mindful of these different things that are going on, how did policies affect Jessica, and not only Jessica, and I put the question in the chat, but how did policies affect Jessica and her family? Like right from the beginning, what were some of the things that were going on?
Folks, feel free to come on mic and come on camera if you like, or simply raise your hand. We'll call on you and put it in the chat if you want to do that as well. We're going to give some opportunity to do that.
What are some thoughts and some reactions? I think some may be typing, but I'm about to call on some folks. Dr. Harrison? Oh, please unmute.
I was giving everybody a chance before I talk because it sounds just like my community. Yeah, and so this community was built in the 1970s. It was student housing for LSU students. And so all of them, there are fourplexes and duplexes, but all of them have like right at 1,000 square feet of space, living space.
Mhm.
And so they have like 2 bathrooms, 2 bedrooms and 2 bathrooms because, you know, it was meant for student housing. So that went on for about 30 years, and in about the late 1990s, well, 25 years, so late 1990s, the LSU students started moving out, and then low socioeconomic African Americans started moving in. But then repairs were not done, they were not attending to the repairs that were needed. And it continued to downgrade. And then when Katrina came in 2005, folks from the New Orleans area who were displaced, they moved into the community because either they had relatives or it was a low income place. And so they moved in, and there was a clash, and, you know, we had criminal behavior, homicides, and all that sort of thing. And so that's when we came in. So everything that you're saying, it all happened right in this community. So, and my takeaway from this is to encourage other people, you start somewhere. Okay, and so we started with renovating the park, and that became the hub of the community. We still have so many other challenges to overcome, but you start somewhere.
Absolutely.
Cerise, I don't know if you're able to see the chat, but Shanika offered that she was disadvantaged from the very start with her parents and their disparities, their own disparities that they had. I think the context in which she was raised was one. Dr. Webster, Dr. Dr. Webster said she recognized that daggone apartment.
Oh yeah, because she lived there when she was a student.
Amen. Amen. I was struck by the fact that decisions that affected other decisions that affected Jessica's health. So the decision not to have certain transportation kind of support affected the decision about whether or not there was going to be an actual supermarket within the community, which affected access to, you know, healthy foods and those kind of things. The fact that a lot of these political determinants are always operating but are virtually invisible, and we walk by them every single day was the takeaway that I had from the video that you offered.
Mm-hmm.
Please, folks, raise your hand and offer your thoughts. What did you see?
And I like Dr. Webster, a cycle of poverty. So, and that's exactly what we see happening, is a cycle in the conditions that perpetuate that aspect of it.
Uh-huh. You know, and I was looking at when you talked about the fast food, you know, oh my gosh, the children just eat chips all the time. Last week, we planted 34 fruit trees in our park.
Nice.
So in 2 years or more, they will have figs, persimmon, not persimmon, Japanese plums, oranges and lemons. And then we're gonna do blueberries and strawberries shortly.
Awesome.
Do you know
Wonderful.
when I first came to the US in 96, I came straight from Lisbon to Baton Rouge, and we have transportation system that works. I never need a car in my life. It's like having a car is even a problem in a big city. So come to a place where you don't have a bus, you don't have a subway, you don't have a train. It was problematic because how there is no walking distance supermarkets. There is nothing walking distance. And I'm like, how these people go shopping? You know, so there is no bus, there is no public transportation, and there is nothing around where people live. Like that was like my mind to go around that is something.
Absolutely. I
Cerise,
appreciate you sharing that.
Cerise, I think, and Jenna, please let me know if I'm mistaken, but I think I saw your hand. If you have something, please feel free to come off mute. There you go.
Yeah, no, I just had my hands clapped for the
Oh.
fruit trees.
Okay, that's good. Thank you.
Do you have an additional thought though? Is there enough information for the video?
My coworker and I were just talking about it, and I've seen that video before, and it is very compelling. And we're even in a more rural area here in Bogalusa, and I don't know the answer. I want to help, but I don't. It's just a cycle, as was mentioned, and I'm not sure how to break it.
Yeah, and I think the first step of breaking it almost goes back to what Carlton had stated,
Yeah.
is ensuring that you're aware of it. Because we can live our lives in our transportation, in our communities, and not be aware of the conditions that the individuals that we're called to serve are living in.
Right.
And all these barriers. And so when we say things, well, like, go get a job, and
Right.
you know, and there's so many myths to folks, especially myths to folks in poverty. They don't work, they're lazy, they do this and they do that. In Jessica's case, that was not the truth. Working, didn't get offered health insurance, all the different benefits. And so I think ensuring that we meet individuals where they are and allowing them to share their story and be cognizant of the systemic barriers that play a part in the process and services, and of them engaging in our services. Like if someone has to take 3 buses, and so we can't have, well, you're 15 minutes late and you don't get to see the doctor. Because be mindful of the challenges that are, the individuals that we're serving may have to, obstacles to receive services.
The disparities are so obvious where Jana is. Jana, isn't there like a development called Money? What's the name of that? Is that in Bogalusa or in Washington?
I'm not sure. It's a company.
Oh, no. It's a subdivision. It's a
Money Hill. Money Hill.
Money
Yes.
Hill. That's what
Yes.
it's called.
Yes. It's in St. Tammany, though.
Yeah, and so you got one
I don't live
side, you
there.
got Money Hill. Can you imagine somebody named the subdivision that?
But yes, and I thought, like, when we went for the mental health training in Bogalusa and we drove by Money Hill, I was trying to understand why a neighborhood has even that name. Why? What is the purpose? Like Money Hill? Okay.
Well, I think the origins of that area is they had some sort of trees that were originally there that had some sort of, I don't remember if it was I think they were called tung oil trees, maybe it was the name of them. And they brought a lot of money to that area because they harvested whatever that was. And so that originally was called something to do with the trees. But that, I don't know if that's accurate. That was just kind of what I was told, but I could be very wrong.
Very interesting name, Jana. Very interesting name.
Yeah.
I'm enjoying this, but I have to leave.
Oh.
Okay, well,
Thank you,
for
Dr. Harrison. We are
sharing,
about to
engaging,
finish
Dr.
though.
Harrison. I appreciate it. Well, with that being said, I'm going to just wrap up. I know we're getting close to the end, and I want to make sure that I honor the time and space. And I appreciate the level of engagement of everyone, and where I kind of where I want to land is here. It's really about us doing the work and engaging in doing the work. Here's just a depiction of the political determinants of health that really kind of breaks out how it all plays together. But I really want to land with conducting our work through an equity lens and really ensuring that you're examining your policies and practices to assess how equity is incorporated into our process and outcome. And as Carlton mentioned earlier, it's by asking ourselves a series of questions. And it's really thinking that these questions are giving, it's given to the process that deliberately reflects our values of what we said we want to do. So if we're about equity, and equity means for everyone, we did, like I said, that beginning definition, we want to ensure that everyone in our community is thriving. That's the point of equity. If that's our values, that it really ensures, and if you ask these equity questions, it'll surface and minimize the negative impact of bias. But the key thing about an equity lens is that it will not tell you what action to take. It helps you discuss with your teams, discuss and reflect on the equitableness of the action and the decision-making process. We have to move past assumptions. And I think that that's what's critical. And that requires you to do the work, really reflect, explore, learn. And in some cases, we have to unlearn. I'm always learning, and really commit, honor, question, challenge, and accept. And really, that's the point of rolling up our sleeves. So if your equity work does not include doing these type of things, I would really challenge you to say that you might not be doing the equity work, because it's not easy. That's why it's such a challenge. And so I want to end with some of these questions that we've mentioned. And it really, these are some of those questions, central questions for existing programs and policies. Because I said, if you're going to do any equitable work, you're going to look at those different areas. And so central questions for existing programs: what changes did you see in the community and population? And how did these changes differ from what we expected to happen? How are communities benefiting from your work? These are questions that we need to ask. And then, what communities are not able to benefit? Okay. And then I like this next part. The question is why? Because when you ask this question, you'll know, if someone would have really, let's take Jessica as example, to really stop and talk and have an understanding of what she was going through. And if we don't ask the individuals that are dealing with landlords that are, that are not treating their client, their tenants right, there was all of these systemic things that were silencing Jessica, that was creating barriers. And so if we don't ask the why to why certain individuals aren't thriving, we will miss the mark, and we'll have these cycles of poverty, cycles of harm continuing. And then the next question is, do the impacted communities have power in decision making? Are the appropriate institutional partners part of the decision making process? So when we're thinking, if you're in this work and you know that, I work at a university, but we need a partner with K through 12, then I have to make sure I have the right partners at the table. How are impacted communities involved in defining success? Success should not be from our organization. It's always in partnership with communities. What mechanisms exist for affected communities to hold decision makers accountable? We need to be held accountable to our work. It shouldn't just be the grant organization holding us accountable. Our communities need to be holding us accountable. And how are results being evaluated? We need to evaluate every step of the process to really have an understanding of what's working and what's not working. And then this last component that I'm going to address, have you communicated results back to all the impacted communities? The communities and not just the ones who benefited, but those also who were not able to benefit. So these are just ways to examine your work and those strategies to really think about, okay, am I conducting my work, and really moving past assumptions. And so that's really what I want to end with, is really giving you that, just some nuggets and some thoughts about what you can apply, conducting your work, and being intentional about everything that you do in this process. And so I like to always end, are there any questions as we have these last few minutes? I wanted to give space.
Dr. Tolbert, I saw that you came on. Was there anything that you wanted to offer or share as we're coming towards the end of the session?
Yes, this was a very good good training. Thank you, Dr. Cerise, for the information. Thank you all for your participation. Thank you, Carlton, for actually putting this on for us, this series. It was good. And so with that, just everyone have a good afternoon. Unless, Carlton, there's something else you would like to say.
I thank you so much, and thank you again for the opportunity. Everyone, if you wouldn't mind, like in your using your emojis or in whatever way you want, please let's offer our thanks to Dr. Cerise Hunt. Thank you for an excellent presentation, Cerise. Thank you for bringing us not only good information, but also some really, really practical, tactical things that we might be able to do, so that this doesn't have to be just a conversation that we have where we're talking about this issue and the challenge, but you actually gave us some things that we could begin to think about within our communities. Folks, I'm put on the screen a QR code, excuse me, that you can use your phone or do whatever to be able to have access to the evaluation. That's very important for the state and for LCPR. So please utilize that. I also put the link in the chat, so look for it in the chat. And with that, Louisiana, you all are my heart. Thank you so much for your participation.
Oh, Carlton froze.
Carlton froze,
Oh,
and
Carlton froze.
yes,
Well, thank
I
y'all.
think you will be back. Oh, but thank you. Oh, Carlton is back. Is back.
Go ahead. You got it, Paula.
Okay, I was just thank everybody, and please fill out the evaluation. I will be send certificate soon, and we will be sending the CEOs after we receive your evaluation. So if you have any questions, please let us know, and I hope you have a really good the rest of your day.
Yes, thank you all. Such an awesome group. Thanks for engaging. Y'all made my day.
Thank you, the series.
Appreciate you all. The evaluation link is in the chat, and we look forward to getting you all the information. Yes, the PowerPoint will be made available as well as the recording.
Thank you, Carlton, for that, and we will be send that to them. And we are doing great here.
Perfect.
Okay, everyone. We don't want to remove you from the room, but you can exit by yourself. You can just leave by yourself before Paula start removing you. Okay, thank you.
Oh, would that mean me too? Okay.
No, that's okay. You can stay right there. No.
I'm working off of two devices here because the camera doesn't work on my computer.
I know
I
that
have it on my phone. So
I don't want you to go anywhere. I want you to stay right there. So I'm start removing people now. Okay, I just have one more. Okay. Okay.
People haven't come back to the screen yet.
Okay. Okay. It's
So
just
did the
us.
recording and hold.
I'm gonna stop the recording.
Yeah, you can stop recording, Carlton.